Bismillahirrahmanirrahim. As you all know, we were discussing ATLS and trauma before all this unfortunate situation happened. So we will now continue our lectures from there. And today we are going to discuss trauma to different viscera inside the abdominal cavity. By the time you have reached to this level, that now you're focusing on trauma to the different viscera, what you need to know, what you need to understand is that you've already performed the A, B, C, D, E of ATLS. You've already managed all the life-threatening issues that the patient may be facing, and now you've moved on to the secondary survey and definitive treatment. So first of all, we will discuss trauma to the liver. Liver is the largest solid organ in the abdominal cavity, and that makes it prone to injury, both in blunt and in penetrating trauma. But isolated liver injury is not that common. Isolated liver injury means that if there is a trauma, only the liver is injured, nothing else is injured. That is in almost 50% of the cases, but more than half of the cases, liver injury is always associated with some other form of injury. It is associated more so with blunt trauma rather than with penetrating trauma, but it may be also be involved in penetrating trauma like firearm injury or stab wounds as well. And the large size, the structure of the tissue of the liver, all of these things make it prone to injury, and especially because the liver has sinusoidal vessels. The sinusoidal vessels have very thin walls and they are high flow vessels. So even a minor injury may lead to major bleeding. But the good thing about liver trauma is the liver has very good hemostatic function. So if there is a minor injury, or if there is a small lacerated wound, usually the bleeding will stop by itself. We really don't need to do anything much for it. But if the laceration is deep, or if the injury is big, then it will bleed profusely and it will lead to problem for the patient. So how will the patient present? The patient will present with history of trauma, history in the form of a road traffic accident or fall from a height or penetrating injury. When we were working in the surgical emergency of Allied Hospital, the most common cause of liver trauma was a motorcyclist involved in a head-on collision with another motorcycle or a car, or as I've mentioned previously, वो जो गधा गाड़ी के आगे जो दो rods होते हैं ना, the bamboos of the ready, that was a very common cause of liver injury. If you examine a patient who has been involved in an RTA, what you'll see he'll present with complaint of abdominal pain. The abdominal pain may be radiating to shoulder, and if the patient is going into shock, the patient may have altered sensorium. The signs that you will see will be, the first thing you have to look for is bruises on the abdomen, specifically bruises in the right upper abdomen, right upper quadrant of the abdomen, right hypochondrium. Along with that, the patient will have tachycardia and tachypnea, both of these indicating that there is ongoing blood loss. If the blood loss is significant, the patient may be in a hemorrhagic shock, and when you palpate the abdomen, if there is blood in the peritoneal cavity, there will be tenderness and guarding, and generalized peritonism may also be there. But if it's an isolated liver injury, the peritonism will take some time to develop. If there is some other associated, for example, if there's a gut injury along with it, then peritonitis will set in earlier. So if you see a patient, if you suspect a patient is having a liver injury, how do you proceed? First of all, as we routinely do, we proceed with investigations related to the blood, hematological. So we get the HB levels done. I've mentioned this previously as well. A spot finding may be significant, but a change in finding over time is much more significant. So for example, if you receive a patient and you send a CBC sample and you get a hemoglobin of let's say 11 or 12, and you repeat the hemoglobin levels after 2 hours and the hemoglobin levels have fallen down to let's say 8 or 9, that means there is significant ongoing blood loss. So hemoglobin level is the first thing, and obviously liver function test If they're deteriorated, especially alkaline phosphatase and ALT, AST, they will signify hepatocellular damage. Then there are a few specific things that you might be able to do, and first of all, the thing that is commonly done in emergency departments is a diagnostic peritoneal lavage. Diagnostic peritoneal lavage means you inject 1 liter of warm saline into the peritoneal cavity, you let it stay there for a while, and then you try to aspirate it back. If you can aspirate 10 cc's of pure blood, then that means there's bleeding and you need to explore. Other than that, if there's fecal matter or bile, or if you aspirate the fluid and then you send it to the lab and you find that there are more than 100,000 RBCs or more than 500 WBCs per ml of the aspirated fluid, all of these are indications for exploration after diagnostic peritoneal lavage. But the problem with DPL, it cannot rule out retroperitoneal injury, because retroperitoneal injury will not lead to any spillage into the peritoneal cavity where we are actually putting in the saline. And DPL has lost favor among surgeons since we now very easily have availability of CT scans in emergency departments all over the nation as well. So the next obvious test is an ultrasound abdomen. But when we talk about trauma, we are not talking about an ordinary ultrasound. We are talking about FAST scans. These are called FAST because they stand for Focused Assessment Sonography in Trauma. Okay? Well, obviously the word stands for fast, and obviously it's also very quickly done, and it can be very easily repeated. What we do is we just put the probe on the abdomen and we look at 3 or 4 areas. What are these areas? Pericardium, the flanks, the pelvis, and the pleura. We don't look in detail, we just look at these 4 places, and if there is any fluid in these places, that means there is hemoperitoneum and we need to explore. FAST is highly sensitive, highly specific, it can be easily repeated as many times as you want. And if you go for a further sophisticated test, then we move on to a CT scan. This is the standard method for evaluation for vitally stable patient. This is a key point. If the patient is hemodynamically unstable, you cannot send him to the radiology suite to get a CT scan done. So if the patient is vitally stable, then standard method is a CT scan. CT scan with contrast will give you a much better view, and even in patients who are being kept conservative, CT scan may be used to monitor the healing of the injuries. So now we have decided that the patient has a liver trauma. What to do with him? If the patient is hemodynamically unstable, then we don't have any choice. If the DPL has indicated it, or if we are still just suspecting, we may have to do exploratory laparotomy. In such scenarios, we don't really worry about going for a negative laparotomy. A negative laparotomy will not do patient so much harm. But if we miss a bleeding liver, that will be life-threatening. On the other extreme, if the patient is hemodynamically stable, then we need to grade his injury and then manage according to the grade of the injury. How do we manage? So whenever we are thinking about liver injury, keep in mind the liver may not be the only injury. Liver may be one of the injuries. So keeping that in mind, resuscitate the patient, give him IV fluids, give him blood, pass in an NG tube to perform nasogastric decompression, pass in a Foley catheter to monitor the fluid output. If the patient is bleeding too much, if he is going into shock, you may consider transfusing blood, cryoprecipitates, colloids or crystalloids, whatever you have available at your time. And then you assess the grade of injury, and according to that, you treat the patient. So these are the grades of liver injury. They are usually assessed on the basis of findings of the CT scan. As you can see, there are 2 different columns. One is a hematoma, the other is a laceration. So grades are from 1 to 6. Grade 1 is a hematoma, subcapsular hematoma, which is covering almost 10% surface area of the liver. If this starts to increase, if it goes to less than 50%, it's grade 2. If it goes to more than 50%, it's grade 3. These are subcapsular. If there is a hematoma in the liver parenchyma, then we are straight away on to grade 2. If that intraparenchymal hematoma is less than 10 cm, it's grade 2. If it becomes more than 10 cm, it's grade 3. Now when we talk about grade 4, then that hematoma has either expanded too much or it has ruptured into the peritoneal cavity, and now it's leading to bleeding. Considering the laceration, if the laceration is less than 1 centimeter, it's grade 1. If it's 3 centimeter, grade 2. If it's more than 3 centimeter, then it's grade 3. If the laceration is big, that it's causing parenchymal disruption of almost 75% of a lobe, or there are less than 3 conort segments within a lobe, then we call it grade 4. We'll talk about conort segment later on. Grade 5 and grade 6 are now vascular injuries. Grade 6 is simply hepatic avulsion, or that means that all the blood vessels leading to the liver are just torn away. The liver is now floating and the vessels are obviously bleeding. If we are talking about grade 5, it's a bit less severe injury. What you need to understand, if you just look at this chart, what you see is up to grade 3 are hematomas, which are contained in the liver or in the liver capsule, or it's a very small laceration which, as I said, liver has good hemostatic function, they may stop bleeding by themselves. So just looking at this table, what you can guess is that in the first 3 grades 1, 2 and 3, we may be able to keep the patient conservative. We may be able to proceed with non-operative management. In grade 5 and 6, we definitely have to proceed with the operative management. Grade 4 depends upon the patient's condition. If the patient's condition is relatively stable, you may try to perform a non-operative management, but if the patient starts to deteriorate, then you will have to urgently intervene. Pringle's maneuver, over here it's mentioned, it's Pringle's maneuver. Pringle's maneuver is an operative measure in which, when we have opened the abdomen and we are looking at a bleeding liver, so before proceeding to suturing or any other thing, we just pinch the blood vessels going into the porta hepatis between forefinger and the thumb. We just pinch them together, stop the blood flow. That will reduce the bleeding from liver injury, giving us some time to repair that injury. In severe injuries, our management options will include damage control surgery, perihepatic packing, hematography, vascular ligation, resections which may be anatomical or non-anatomical, or intrahepatic balloon tamponade. Very briefly, hepatography means repairing the liver. Vascular ligation means you just ligate the main vessel supplying the liver so that the bleeding stops. In resection, you remove the damaged area, and intrahepatic balloon tamponade, it's actually an endovascular approach in which you put an catheter into the blood vessel and you inflate the balloon which is supplying inflate the balloon in the vessel which is supplying the damaged area, which will eventually stop the bleeding. This is a simplified algorithm of how we manage a patient with a liver injury. If the patient is stable hemodynamically and we have to perform laparotomy for some other cause, for example, if there is associated gut injury, which is usually this is identified on the basis of CT scan, we may apply a simple suture, or we may coagulate the area, or we may put a hemostatic agent there like a Curasponge that you may have seen in the OTs as well. If the patient is unstable hemodynamically, then we need to proceed to damage control surgery. Damage control surgery, what I need to define here is, what is damage control surgery? Damage control surgery, consider a scenario in which you have a bleeding patient but you don't have any resources. Let's say you don't have any blood arranged, so you just go in, you stop the bleeding and you come out without doing any definitive treatment. You just stop the deterioration of the patient and you just come out, and at a later stage, after 48 to 72 hours, when you're fully prepared, then you re-explore and you do a definitive measure. If the patient is hemodynamically unstable, then you may have to go for damage control surgery, packing or resuscitation. If you open the abdomen and the bleeding has already stopped, you just stop the operation, come out, send the patient to ICU, and you may go for angiographic embolization. If the patient is still bleeding actively, the first thing you do is a Pringle's maneuver. You just hold the vessels going into the porta hepatis and you stop the bleeding temporarily. then you may proceed on to repairing that laceration or resection, or as we discussed, the other options that we discussed previously. What we need to understand, the two important concepts in liver trauma: the damage control surgery, as I already mentioned, and the second is the death triangle. Whenever there is injury to the liver, there are three things. All three things independently can kill a patient, but in liver trauma, sadly, all of these three combine. First of all, patient develops hypothermia. The resuscitation that we do actually contributes to this hypothermia. When we give cold saline or blood or whatever, it contributes to this hypothermia. Then there is coagulopathy, because the liver was itself involved in making the coagulation factors. Now the liver is damaged, there's coagulopathy, and the blood we are transfusing, if it's stored blood, it will further deteriorate this condition. And acidosis, again, the blood we are transfusing, it has anticoagulant which has a low pH and acidic pH. Liver injury itself leads to acidosis, and our resuscitation contributes to it. So this is the death triangle which occurs in injuries to the liver. Angiography, as I already mentioned, may be done in actively bleeding patients to embolize small vessels, or we may do it later on to embolize big vessels. So moving on to splenic injury. Spleen is the second largest organ, and the clinical presentation will be very much similar to that of liver injury, because both of these organs, if they get injured, they bleed profusely. So 31 to 35% of abdominal solid organ injuries will involve a splenic injury, may be caused by a blunt or a penetrating injury, may be idiopathic splenic rupture. Sometimes you don't find the cause for a bleeding spleen, for a ruptured spleen. That is called idiopathic. And in a diseased spleen, if the patient already has some problem, which if the patient has lymphoma in which the spleen is enlarged, or if the patient has thalassemia, or if the patient has a splenic abscess, a diseased spleen may rupture without any cause as well. So whatever the cause, the patient bleeds, the patient presents in shock. Now in this case, the pain will be in the left upper abdomen and radiating to the left shoulder tip. This radiation to shoulder tip is due to irritation of diaphragm, both in the cases of liver injury and in the case of splenic injury as well. You might find abdominal bruising. The patient may be hemodynamically unstable. Investigation and initial resuscitation is similar as was in the case of liver injury. And again, before proceeding to treatment, we have to perform grading of splenic injury. Again, the two main types of the criteria for our grading: one is a hematoma and the second is a laceration. It's very much similar: hematoma less than 10%, hematoma less than 50%, and hematoma of more than 50%. Laceration less than 1 centimeter, laceration 1 to 3 centimeter, and laceration of more than 3 centimeter. The first three grades in hepatic injury and splenic injury are almost the same. But in grade 4, now there is a laceration of segmental or hilar vessels, which causes major devascularization. Almost more than 25% of the spleen is now devascularized. And grade 5 is a laceration which completely shatters the spleen, or there is avulsion of the hilar, splenic hilar vessels. Again, same as in the liver, the first three grades have hematomas. Hematomas may not be bleeding actively, so first three grades may be managed conservatively, but grade 4 and 5 have to be operated. This is again a treatment algorithm. If the patient is hemodynamically stable and the patient has a penetrating or a blunt trauma, you go for a contrast enhanced CT scan. This CECT stands for contrast enhanced CT scan. If you find anything other than splenic injury, for example gut injury or anything else, you may need to go straight away to exploratory laparotomy. If there is an isolated hepatic or splenic injury found on CT scan, then you need to decide you need angioembolization or not. AE stands for angioembolization. If it's an isolated injury, if it's grade 1, 2 or 3, then you can proceed to NOM, non-operative management, with or without angioembolization. If the patient is hemodynamically unstable, as the case is on the other side, and If the patient is hemodynamically unstable, you have to go for exploratory laparotomy. If it's liver, you just perform a liver packing. You put sponges around it, you pack it, you pressurize it and leave it. You just come out, and on a later date you may need to redo the surgery. This is called damage control. If the spleen is injured, you just go for splenectomy. Okay, moving on. So whenever we open a patient for splenic injury, we have two options. Either we perform a splenectomy or we repair the spleen or splenic salvage. In our setup, in our circumstances where we are usually short of blood, the patient presents late, there are other associated injuries, in our setup, splenectomy is usually the preferred option. The indication including hemodynamic instability, the damage control regardless of injury grade or presence of other organ injuries. As you can see, in splenic injury, even damage control surgery as we did in liver. In splenic injury, damage control surgery is splenectomy, nothing less than that. And in some cases, we may go for a splenic salvage in a hemodynamically stable patient when you've explored for some other injury, or if you have just done a laparotomy and you found that the splenic injury is not grave, you just put a topical hemostatic agent on it, for example these cure sponges, etc. You may perform a partial splenectomy, removing the devascularized segment and just suturing the rest. You may wrap the injured spleen in an absorbable polyglycolic mesh. These meshes are not really available in Pakistan, but theoretically these can be done. Lastly, the pancreatic injury. In liver and spleen, the scenario was very much the same, the investigations were very much the same, the treatment was very much the same, but pancreatic injury is different. In this injury, first of all, pancreas is located in a different plane. It's located retroperitoneally, so the signs and symptoms and everything else will not be the same. Secondly, pancreas won't bleed as much. Pancreas will cause other problems, so we need to deal with it a bit differently. Whenever there is blunt trauma to the central abdomen, the junction of pancreatic head and body is crushed against the spinal cord and the pancreas is split into two parts. That is the most common presentation that I have seen in my career. Other indications that you may find on CT or on clinical examination, if there is retroperitoneal fluid or hematoma, suspect a pancreatic injury. If there is free abdominal fluid and you can't find the cause, again think of pancreatic injury. Or if you get a CT scan and the CT just tells you there is edema of the pancreatic tissue, again think of a pancreatic injury. In investigations, you may go for blood serum amylase levels, or if there is fluid in the abdominal cavity or in the retroperitoneal space and you've aspirated it through an ultrasound guided procedure, you may perform amylase and lipase levels in that aspirated fluid. The best test for pancreatic injury is CT scan with contrast. ESCP may be done, but this requires logistics. This requires a hemodynamically and clinically stable patient, and if the resources are available, then you may perform an ESCP. In our setup in Pakistan, ESCP is still not widely available. So this is good in Western setups where an endoscope and a good endoscopist is available in the emergency department, but in our setup not so much. And if you cannot find the cause, the patient is clinically deteriorating, you may just open him up and see what the cause is and then treat accordingly. First thing, as in the previous two sections, identify the grade of injury and then proceed onwards. The grades are 1 to 5. As you can see, grade 1 is again it might be a hematoma with a mild contusion without duct injury, or it may be laceration which is superficial. In grade 2, there is a major contusion or a major laceration without duct injury. Grade 3 is distal transection of parenchymal injury or parenchymal injury with duct injury. Keep in mind, in pancreatic injury, the important thing is the duct. If the duct is not injured, you're not really worried because there won't be any problem. There won't be any spillage of pancreatic juices. But if the duct is injured, then we are in trouble. If the duct injury is towards the tail of the pancreas, then it's grade 3. If the injury starts becoming proximal, then it becomes either grade 4 or grade 5. In grade 5, there is massive disruption of the pancreatic head. So how do we treat? If it's grade 1, in which is either a small laceration or a small hematoma, we just observe. Or if we have opened him up for a different indication, then we need just to put omentum on it, cover it with omentum, and simple put a drain in it, external drain. So if there is any seepage of fluids, you just drain it out. Same treatment for grade 2 injuries, but now when we move on to grade 3, where there is disruption of the pancreatic duct, you may have to perform distal pancreatectomy plus minus splenectomy. Distal pancreatectomy means you remove the damaged area of the pancreatic tail, and because splenic hilum is very close to the pancreatic tail, if spleen is also injured, or you cannot remove the pancreatic tail without removing the spleen, you may remove the spleen as well. Or you may have the second option of Roux-en-Y distal pancreatico-jejunostomy. You anastomose that transected part of the tail of the pancreas with a jejunal loop, and you make a continuous channel there. In grade 4 injuries, now we are talking about serious injuries, we either perform a pancreatico-duodenectomy, Whipple's, in which the head of pancreas is removed, the damaged area of along with the duodenum, the damaged area is all gone, and now we just anastomose the distal part of pancreas to the jejunum. We may perform a Roux-en-Y distal pancreatico-jejunostomy, as we discussed before, anterior Roux-en-Y pancreatico-jejunostomy, in which we anastomose the jejunum to the anterior surface of the pancreas. We may place a stent endoscopically. If we have a good endoscopist, we may go into the duodenum and from there into the major duodenal papilla and place a stent which crosses all the way through the pancreatic duct, providing a good drainage. And if we have an unstable patient, we are not really prepared to do much for him, we may go for damage control option, in which we just put in 2 drains, one on the right and one on the left in the lesser sac, and you provide adequate drainage. Obviously, this is not a treatment, this is just a temporary measures until we can do something about it. Grade 5 injuries were the injuries in which the head of the pancreas was damaged, so we need to do a pancreatico-duodenectomy in those. Indications of conservative management. When do we keep the patient conservative? Either he is hemodynamically stable, his fast scan is negative, and there is no indication of pancreatic injury in CT scan. Even those patients who are being kept conservative need to be kept under observation for 72 hours. Indications for exploration are peritonitis, hypotension, meaning the patient is going into shock, and a positive fast scan, evidence of disruption of pancreatic duct on CT or on ERCP, and gradually deteriorating patient or increasing enzyme levels. What you need to understand in pancreatic injury is pancreatic injuries don't appear immediately. They take some time to develop. The patient takes days to deteriorate. So a high index of suspicion is must to identify and then eventually treat a pancreatic injury. See, this is the treatment algorithm, just go through it, nothing new here. And what are the complications of pancreatic injury? Complications include secondary hemorrhage, which may occur 7 to 8 days later. A pancreatic fistula. If the duct is injured, we missed it, then it may present as a fistula. Peripancreatic abscesses. If there is collection of fluid or blood around the pancreas, it gets infected and it becomes an abscess. Pancreatic pseudocyst. Again, we have discussed this before. Fluid collection in the lesser sac, which becomes walled off in 6 weeks, becomes a pseudocyst. Recurrent pancreatitis. A damaged pancreas may repeatedly become inflamed and causing recurrent pancreatitis. Splenic artery aneurysm. Splenic artery passes just above the pancreas. If there is injury to the pancreas, it will irritate the splenic artery, causing an aneurysm. Or endocrine or exocrine insufficiency. For example, the patient sometimes becomes diabetic after having a pancreatic injury. This was all about today's injury to these 3 viscera. If you have any questions regarding this, you find a way to contact me through your CR or whatever group you have, and I'll be glad to answer those. Thank you very much.